Good evening, everybody, and all the dignitaries on the dais. My namaskar to all the teachers and also in the audience. I think I'll tell you how we go about, surgical training. Because surgical training is. I have some slides also. I have some slides also. Can you put it for me? Surgical training is very unique and very specific because it poses risks to the patient. So if you're doing, if the surgeon is not well aware, and it could harm a person, and the very basis for the medical practice that do no harm first. So no harm first is, I think, is the principle we that follow, and that actually has to be maintained, observed very meticulously, especially in the surgical training, because there the risk of doing harm is maximal. Now, why we need it is because if you look at the scenario, I think this data was collected somewhere in 2006 to 7. I think Dr. Dogra and Dr. Ravi were involved in that. And it was found that they actually inspected a lot of medical colleges in Andhra Pradesh, and it was found that the surgical training infrastructure was, even for infrastructure for ophthalmic training as a whole, and particular surgical training, was actually very negligible. And in spite of some institutions having the infrastructure, that was not being put to use. So that was very actually concerning matter. And now if you look at the national curriculum for ophthalmology residency training program, at least because cataract surgery is kind of the main surgery, because cataract blindness is still the commonest cause of visual disability in our country, maybe around 60% or perhaps more. So at least 50 surgeries are recommended to be done by the resident training. Higher than this would be preferable. Like Dr. Karamjit said, I think he said that if you go to 75, 80, your actual skill level goes high up, but at least 50 should be there. But are we able to give that much surgery? So I think my own impression is that very few residents actually during their training programs during residency get that much exposure also. And also there's another publication where there are a lot of lacunae have been pointed out in the existing system of training, especially for cataract surgery. And most of our medical colleges are still focused exclusively on small incision cataract surgery, which is not bad because because of the cost involved in it. But I think the other techniques of surgery is not only cataract but other glaucoma, they also need to be at least be there and taught to students. So there are a number of barriers actually which prevent, and very important thing I said earlier is the risk to the patient. Because why I won't give surgery to a resident? Because I am worried, because the patient can get harmed, and then it will, then you have the medical, legal, and other issues that come to you, so you have to deal with them. So, and then also the lack of the trainers, because if you really want to train and then you have to be, you have to know how to train a person. And I think that has already been alluded to. And also this happens because there's a lack of structured training program. So unless you have a structured training program, you can't just one day ask a resident, okay, come to the theater and do cataract surgery. And that happens many times when the resident doesn't know what the patient is or what his condition is. He has not been involved in the work of or the investigation of the patient, and suddenly you can't give cataract surgery to. So it has to be a structured program. And of course, as I mentioned earlier, the infrastructure has to be there. So to get optimal results, you have to have a phase-based training. So you have you give the information, then you have observe the skills, and finally the person should be able to doing the surgery. And cataract surgery or any surgical training is basically, if you want to improve the surgical skills, and if you have a structured program, so it has many advantages because it lowers complication rate, it reduces the learning time, and in that already mentioned the wet labs, phaco trainings, and they are kind of very useful. Now, what with the problem with the SSTs is that they are kind of a for in between. So you go to a conference or attend a special training program, and then you are doing it. That it has its role, but I think to develop that muscle memory, as I think Karamjit also referred to, you need to repeat these tests often enough. So if you're just doing one workshop once in a year, twice in a year, that is not sufficient. That's useful, but it's not actually sufficient to train a person. So therefore, a stepwise approach and on a regular basis is required. So from wet lab to operating room, I think this is again a very good way to expedite surgical proficiency and also decrease complication rate. So this is how we do it in PGI. We actually start from the simulators. They're very expensive machines, but whenever they're possible, I think we could do should be used. So our facility is actually open to the resident in our city, basically. So we have a medical college. I think they send their resident to us for the initial training on a simulator. See, here they actually get the hand-eye coordination. The first step is actually the hand-eye coordination. So you have to, and that can be taught very well on a simulator. And once, and there are kind of different levels. So once they have gone through the different levels, they can, do that. The second thing is actually then you have to go through in the gore side, where in animalized. Now there, if you're doing a phaco, so first you have to have hand-eye coordination, then you have to have the foot, hand and eye coordination. So the actual machine, but in animal eye or an artificial eye, you get to know the feel of the machine, the phaco, how it vibrates, how to handle it, what's the weight of the equipment, and then you have to coordinate with the 2 feet as well as 2 hands and the eye. So it's a very complex procedure. So unless you have that feeling in the kind of an experimental setting, doing straight away on the patient, then it will be difficult. And also by that time, here you learn the different parameters of the phaco machine, is also how to adjust the microscopes. So all that feeling. So when you are finally going to the operation theater, you are very well equipped. You have all the controls with you. You are confident that you can do the surgery. So another important thing is that when you're doing a training program, so training is not just, I think we should also be, the research component should be built into it. So how do we improve our training programs? So unless we analyze our training programs, so I am running a training program ABC, but is it working or is not working? I think that audit also needs to be done simultaneously. And I think when we started this program, we actually had a kind of evaluation system for people who were without the training program earlier and then after that. And we have actually published this data. And it suggests that if you have a structured training program, it actually shortens your training. It reduces the complication rate and actually increases the success rate and the confidence of the students. So thank you very much. So in conclusion, a structured web program is very important in the training for these residents. Thank you very much.
Thank you, sir.
A brief commentary I want to give about the simulators and their cost and all that. Western world like America or something, simulator is must because there are not plenty of patients to be experimented. So they have to go through simulator. In my place, like in Delhi, I know institution simulator crores. And these students don't want to work on it, don't want to learn from this. They want to sit with surgeon, want to get the free hand. Because they don't bother how many complications will happen, because senior will take care when something goes wrong. In fact, I felt the best thing was that our teacher need to be that much committed that he takes the role of mentor, and this student, he sits with him on the table, gives him the step, get up, go to the next step, then sits again. Whenever he comes a mistake, I go to him again, that see beta, I will do this way, this way. I think that helps a lot. Simulators, in a way, it possibly will add to the values. But since we have a lot of patients, and the children are interested, that see, you have done 60, I have not done 40 even. Subharti, I saw that we got a patient free for 2 days. So free patients were generally liberty that we can little bit be kind of free with them. And these patients, like I saw to it that every PG by third year got at least 50 independent phaco. But with that, teachers virtually has to sit with the child. Teachers with that.
I think that's very important, sir. I think after they have gone through the hand-eye coordination and eye, foot, and machine coordination, I think the program is, we have a structured program where one table is kept only for the resident surgery, and then every day or on the surgical day, every day actually there's a roster, and that roster mentions the patient, the resident, and the instructor, and the instructor is free during that period of time. So instructor has to be, yes, it is mandatory that he has to be scrubbed. And so the way we look at it is what are the critical steps.
Yes,
so if something goes wrong, then the instructor has to take over.
Yes, that's
so because the patient's eye is actually the most important, and I
because
think, as I
lectures,
said,
etc., you
there's
can
no-
learn on many things.
Yes,
on
yes.
the potato and tomato and
Yeah.
anything.
So those
but
coordinations you can
the
develop.
eye of the bakra doesn't do really good. The eye of bakra
it
doesn't
gives
have
you-
good cornea,
Yeah.
doesn't have good lens, and phaco doesn't work on it.
Definitely,
Really.
but it gives you the feeling of, you know,
Yes.
that how to make the incision.
The artificial eye is a much
absolutely,
better
much
process.
better.
That gives you real feeling of cutting the nucleus, real one.
And we have
And made
seen
by
that,
this Madhu, our instruments from Delhi only. It's a real good artificial eye. That makes a lot of difference. But anyway, everyone has his own way, and students, if teacher sits with the students, he remembers lifelong that
Yes,
I learned from
absolutely.
him or her.
But that still happens, because
Yeah.
after this has gone through, I mean, what we have seen is that the instructor or the teacher takeover rate,
Yeah.
you know, at what point the teacher is taking over
Oh, yeah.
in the surgery, those rates have actually gone much lower,
Lower now,
after
yes.
we started the structured program.
Yes.
Actually, Dr. Pandav,
Yeah.
when we were there in the college as a teacher, every surgeon is having this junior resident, senior resident, like that. 2 or 3 were posted accordingly. And the number one, that was third year student, is always having the right hand of the surgeon.
And in our
And
country,
That's
and
very-
then third year,
that's very
third year,
interesting.
once you leave the
Yeah.
OT, somehow,
Yeah.
leave the OT and some different work.
So that's very interesting. Actually,
the second year, we take care of the third year.
and unfortunately in our country, many teachers were not trained. When the phaco
Exactly.
came, many teachers were really not trained.
Yeah, exactly.
So no question of giving phaco because they can't do themselves and they can't teach them. So
So
things
se-
are changing now. Of course, they are
Yeah.
changing very
Since
fast.
that one, sir, actually the second point is what I'm telling, that once the postgraduate after after selection, postgraduate examination, they come to us. The first year for 3 months at least, I rotate everyone to go to the OPD because they don't know the internship, they have not done it. They say to go to OPD, at least syllabus chart, what is the spelling of that one? how to
Retinoscopy
record
नहीं
one.
करते, retinoscopy
नहीं
बिल्कुल नहीं
करते हैं।
सीखते।
नहीं सीखते हैं. So we at least 3 months. They go to the OT. What is the microscope? How many there are bulbs? From where bulb you put the bulb? How you put switch can go? It's to learn everything,
Basic
disciplined
everything,
about
machine,
everything.
how to see
In the
it, how
first,
to-
at least after 3 months, then they have to post it in the units.
Yeah,
That
and
is
as you
the
mentioned,
structure,
I think
sir.
it is also very important because each individual student is different. They have their own characteristics. I think you mentioned of the right hand, the left hand, and when we were going through this program, we realized that some of the students actually, they are doing very well on the wet lab, but when they go to the next steps, there's a problem. Then we realized, what is the problem? Then suddenly it happened that those students were actually left-handed surgeons, and we were forcing them to use their right hand.
Exactly.
So we modified our program because the software can be, kind of adjusted, or the position can be adjusted. So we trained them. No, you are left-handed person. You have to be trained on the left hand only.
True.
So otherwise we are confusing them.
Very true.
So this actually we wrote it up, and this will be coming in one of the publications. I think maybe a few months down the line we'll have this.
Teaching and training program is always having the teachers who have been trained by the
Because
own.
हमारे देश में ये सोचना चाहिए कि हमारी अपर हाफ ऑफ इंडिया अपने बच्चों को सारों को पास करने के बाद अली प्रसाद क्यों जाना पड़ता है, मदुरई क्यों जाना पड़ता है,
Exactly.
वहाँ क्यों जाना पड़ता है? What is wrong with Delhi यार? Delhi or anybody else, big
anywhere.
city, Kanpur or Meerut or anywhere. Why our children after passing MS has to rush to the south
I
centers?
think the focus is mostly like students. They like to pass the exam. There's their primary focus, and
True.
they get like the access to information is easy now. So you can go to the internet, you go to the YouTube, and go. You can learn things. But when it's come to doing it, they lack it. They lack it. And it's not only surgical; it's true even for the other clinical procedures. So I think in this session,
सुधर रहा।
so we have actually modified our training program now. So what we do is, instead of having lectures, now we have surgical, like we have surgical training program. Now we have clinical skill development labs. So we have actually shifted to a different, training mode. So what we do is we call a clinical skill development lab. There we are teaching them, like you teach a surgery, we teach them, okay, this is the slit lamp, this is how the parts, how you switch it on, how you clean it up, how all the basic, what are the optics, what are the different ways of examination on slit lamps. Now we are actually running special classes only for this purpose. And then you go to the higher level when they have to discuss a patient using what was taught the previous week or on the previous days.
आपका
So
तो
then they
आदर्श
use
वाला
it.
इंस्टीट्यूट है ना जी, आपका तो
हाँ,
आदर्श वाला बड़ा है, आदर्श वाला
नहीं
है,
दूसरा हमारा एक
सब कुछ है वहाँ।
हमारा एडवांटेज ये भी है कि
बाकी
we
जो-
we kind of fine tune our academic programs, so we are not entirely dependent on NMC,
Because
so
छोटे
we have
medical
that
college जो
flexibility.
है ना, जिनको ना तो
Yeah.
फंडिंग है,
Yeah.
ना
Th-
गवर्नमेंट
that-
से,
that's
ना
true.
किसी से,
Absolutely.
तो उनकी प्रॉब्लम बहुत
Absolutely,
है।
I understand, but the thing is that we kind of trying to create a model. If it works, a few years down the line, so we are also keeping the data alongside that. Is there any difference in the new model and the previous model? So if it works, then we will make it public, and then at least some people can benefit out of this.
Great.
One
Thank
thing
you.
I would like to, one important point, most of the time what happens, the resident, they have the curiosity to do the case on the same day.
Yeah,
all
extra
these things.
mics.
This is very, very important. How to proceed for that step, surgery. Steps are very important. For making a conjunctival, just I am telling you very, very simple, one step that is conjunctival incision. Like, I am giving example. So first make the perfection of conjunctival. Before that, ask the teacher should ask how to do this particular step. Then ask him to sit down and show me, like make a small cut and make a triangular, so that after coming once you be reposited, at this whole wound should be covered. But nobody is taking care that they are making the right. So the step this is very important. That the step surgery, but make the step. Rather, I have been somewhere else. Though I was knowing everything, all the step in 1995 when I started training for trainer program.
बच्चे जल्दी में
तो वो जल्दी में तो इसलिए steps as give 1 step, 2 step, okay, next one. Go and learn first read and tell me what are the steps. Just enumerate. Just tell how we will proceed. Then please sit down, and the teacher is responsible to sit down. This is very important part. The step surgery. Then otherwise, if you jump whole step, whole surgery, and once any complaint will happen, it will make a depression to him, and he will start doing the surgery for a week or so.
You lose confidence, and then next time again the same.
Next.
Thank you, sir.
Thank you, sir.